Hello, my name is Jamie Weems, and I would like to discuss the topic of aspiration pneumonia in patients with Parkinson's disease. This topic is near and dear to my heart because my grandmother passed away 8 years ago. She had Parkinson's disease and developed aspiration pneumonia. Parkinson's disease is a progressive and degenerative disease, meaning it gets worse over time. It affects the muscles and the ability of the person to control their muscles on their own. This can also hurt swallowing, which can cause dysphagia. Dysphagia is difficulty with swallowing. Patients become unable to properly clear the fluid and liquid from their airways, and then they can aspirate these foods or liquids, and this can lead to pneumonia. Pneumonia is an infection in the lungs where the alveoli get fluid in them and they're unable to aspirate and unable to have proper respiration or oxygen exchange. Aspiration pneumonia is actually the #1 cause of death in people with Parkinson's disease. People with Parkinson's don't die from Parkinson's alone. They die from complications due to the disease, such as aspiration pneumonia. When patients are in the hospital or are in a clinic, there are techniques that can be used to look at how their ability to swallow. One of these invasive techniques is video fluoroscopic swallowing studies, or VFSS. These are used to determine if a patient is aspirating when they swallow. The picture on the left is a picture of one of these. New research by Lee et al. 2016 indicates that performing more non-invasive studies like functional dysphagia scales, which is more like a questionnaire with some little things that they have to do oral motor wise, they may be a good indicator of whether or not a patient with Parkinson's disease is at risk for aspiration. They've actually decided that using non-invasive techniques such as the FDS are preferable when possible to ensure that patients are comfortable, and these tests are more easily performed in the office. They're not as invasive, so the patients will tend to be more apt to do them. So if the patient is more apt to perform the test, then you'll have better data and hopefully less aspiration. When people are in the hospital with Parkinson's, it is important that the hospitals understand that there is a risk of aspiration pneumonia. And this study by Martinez Ramirez indicates that some hospitals actually underperform swallow evaluations on patients with Parkinson's. He looked at a small sample of patients, only 212, and of these, only 8 developed aspiration pneumonia. That's not a very high level. But of these 8 patients, only 1 was given a swallow evaluation prior to developing aspiration pneumonia. So this could lead some patients to developing aspiration pneumonia that could potentially have been prevented if a swallow study, closer evaluation, or prevention had been in place. So maybe some hospitals are actually underperforming swallow evaluations that could be preventative. Another view was from Akbar et al., and they actually looked at lots more data. They looked at, from 1979 to 2010, lots of studies and data that had been turned in on patients with Parkinson's who had developed aspiration pneumonia. And they concluded that people with Parkinson's actually die from aspiration pneumonia at a lower rate than those without Parkinson's disease. So they concluded that this may be due to an increased awareness of the risk of that particular population in developing aspiration pneumonia. So if the hospital is more aware that patients with Parkinson's develop aspiration pneumonia, maybe they're more closely watching those patients and doing more swallowing evaluations and checking them more closely to be sure they don't develop that disease. This reinforces that most hospitals may have protocols in place to watch for and prevent aspiration, but some are still lacking in this area. In conclusion, patients with Parkinson's disease have many options when it comes to feeding therapies and modifications. There are lots of things you can do to help reduce the risk of aspiration. Symptoms of aspiration pneumonia are over on the right: fever, fatigue, cough, shortness of breath, difficulty swallowing, chest pain, profuse sweating, and a bluish skin color. Pneumonia is no joke. I've actually had it a couple of times, not due to aspiration, but when I was in the hospital with pancreatitis, I developed pneumonia twice, and it is nothing to mess around with. You feel terrible when you have pneumonia. So imagine feeling really terrible and having pneumonia and also having Parkinson's disease, where you're already struggling with that as well. Aspiration pneumonia is uncomfortable, and it can cause many other complications. Whenever one body system is taxed or has more strain on it, the other body systems have to work harder, and it can cause even more distress in the patient's body. It's always really important to consider a patient's preference and comfort. Like I mentioned before, my grandmother actually passed away from aspiration pneumonia. She had congestive heart failure caused by the aspiration pneumonia, and she had Parkinson's disease. So the Parkinson's disease caused her to aspirate, which led to pneumonia, which put too much strain on her heart, which caused a congestive heart failure. In the end of her life, she was receiving palliative care and under hospice care, and we knew it was the end of her life. So, for example, we knew the risks of aspiration. We knew she had already been aspirating, but one of the only things that she really wanted in her last few days were caramel frappuccinos from Starbucks. So that's what she had. And even though she had difficulty drinking them, she enjoyed it, and we made her level of care as high as we could during those last few days, her level of comfort. And it's also really important to remember that SLPs are just part of a team that are going to be working with the patient and the family. Obviously, the SLP works with the feeding and swallowing aspects. There are going to be other doctors that are going to be working with the actual pneumonia, respiratory therapist, etc. My grandmother had a cardiologist on board. It's going to be a multi-level team, a multi-layered team of people that are going to be working with these patients. So it's important to know our role and to play our part and to do everything we can to ensure patient comfort. Here are my references. Thank you for listening.